All right, good afternoon, everyone. My name is Ria Suarez with the Cancer Support Community, and welcome to our webinar, Frankly Speaking About Cancer, Immunotherapy Advances in Cancer Treatment, which is hosted by the Cancer Support Community. I'd first like to start by going over a few reminders and housekeeping items. If you would like to listen to today's presentation via the telephone, you can dial in using the conference line and code that you see on the screen. As a reminder, today's call is being recorded and will be made available on the Cancer Support Community website at www.cancersupportcommunity.org. The format of today's webinar will be as follows. We will begin the panelist discussion first, and then we'll move into the open discussion with the audience during the question and answer session. Thank you to those of you who submitted questions prior to the webinar as part of the registration form. A lot of the questions that were asked will be addressed during the presentation, but if you do have any questions throughout, you may submit them through the question and answer box, which is found on the right of your screen. Also, at the end of today's webinar, you will be automatically redirected to the post-webinar survey. Please take a few minutes to complete this survey as your input is of great value to us. I'd now like to introduce the Cancer Support Community, which is the largest professionally led nonprofit organization which is dedicated to ensuring that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. We offer the highest quality social support through our affiliate network, as well as online and over the phone. On this screen, you'll see some of the resources that we provide at the Cancer Support Community. The first one there is our Cancer Support Helpline, which is staffed by licensed professional counselors, which are available to assist you Monday through Friday from 9 a.m. to 9 p.m. Eastern Time. We also have our Open to Options program, which is a research-proven program that can help you prepare a list of questions with your doctor. We also have our Frankly Speaking About Cancer program, which is our landmark education series that provides trusted information on a variety of topics which are important to people affected by cancer. I'd also like to introduce our Cancer Experience Registry, which is a program of the Cancer Support Community and a place where you can go to make sense of your cancer experience. It's a place where you can go to tell your unique story, connect with others, advocate as members of the community, and learn from experts. For more information, or if you would like to enroll in our Cancer Experience Registry, you can visit us at www.cancerexperienceregistry.org. I'd also like to take a moment to talk about our grassroots movement, which helps ensure that people touched by cancer have access to quality, comprehensive cancer care, which includes social and emotional support. Again, if you'd like to learn more about this program or would like to sign up, you can visit our website at cancersupportcommunity.org. I would now like to take the opportunity to introduce our speakers today. Unfortunately, Dr. Kim Lyerly had a conflict come up and isn't able to join us, but we do have the pleasure of introducing Dr. David Carbone and Dr. April Salama. Dr. David Carbone is director of the James Thoracic Oncology Center at the Ohio State University Medical Center. His recent research directions include development of molecular biomarkers to guide patient management and therapy, and molecular profiling of lung cancers and pre-neoplasis to guide the development of novel therapeutics. Dr. Salama is a medical oncologist who specializes in treating patients with skin cancer. Her focus is on taking care of patients with advanced melanoma, as well as melanoma that is at high risk for recurrence after surgery. As the Associate Director of Clinical Research for the Melanoma Program, she oversees all melanoma clinical trials at Duke. She works with other researchers to design new treatments for patients with melanoma, using both immunotherapy and targeted drugs. So at this time, we'll begin our discussion. Our first question here is just opening the conversation about immunotherapy. So Dr. Carbone, we'll start with you. what exactly is immunotherapy?
Well, there's many different kinds of immunotherapy, ranging from cancer vaccines, which are used to give cancer proteins and other types of molecules from cancers and show them to the immune system in a different way, and in the hopes of inducing an immune response. And then there are approaches that are targeted at overcoming cancer immunosuppression. And the recent significant successes have come in that latter arena, where the cancer has arisen because it has successfully avoided the immune system, and through research in that process, we've identified some of the ways cancer has accomplished that, and discovered drugs that can block the immunosuppression and induce the patient's immune system to recognize and kill their cancer when it was unable to do so previously. So basically, immune therapy is figuring out how to use the specificity and sensitivity of the body's immune system to fight cancer.
Great. Thank you. Dr. Salama?
I thought Dr. Carbone gave a great overview there. It's, in a way, trying to kind of use your body's own immune cells, as Dr. Carbone explained. Sometimes, and that's where a lot of the recent progress has been. Immunotherapy is not new. We do use immunotherapy in other ways, be it with antibodies that are certain, kind of man-made versions of certain proteins that can be used to target specific cancers, and those have been in development for many years and used for other cancers. Some cancer vaccines have been studied. And so there are many types of immune therapies that are out there. Probably what's received the most attention recently and a lot of success are those types of therapies that enable a person's own T cells to become more activated against the cancer in a very specific way.
Wonderful. Thank you. So a lot of the questions that came in from the audience, and actually our next question as part of this conversation, is what are the expanding types of cancer for which immunotherapy is being studied? A lot of the participants are asking, will this be expanded into breast cancer, pancreatic, gastric, kidney, other types?
Of course. It's being tested in virtually every type of cancer to varying degrees of success. And melanoma and lung cancer are the prime examples, but it's been found to be active in certain types of colon cancer, as well as bladder cancer and head and neck cancer and multiple other types of cancer.
I would agree. I think it may be easier to list the cancers where maybe it's not being tested or not being studied. It's almost in every solid tumor and even some blood cancers, and some lymphomas, and testing it even in patients whose cancers have come back after bone marrow transplants. I think it's just at various stages of development. Of course, melanoma and lung, and now more recently bladder cancer, have FDA approvals for some of these newer types of immune therapies, and it's really something that's expanding throughout oncology. It's really paradigm shifting.
Great. So for this next question, who responds to immunotherapy? For the patients that are currently on a trial, what are some of the factors that they've seen for the folks who have or who do have a response to the therapies?
That's a great question. I think it's one of the questions we're most interested in because we have therapies that are effective, we know, in some patients, and we know they don't benefit all patients. It's something that's probably going to be different within each disease, and it's going to be hard to pin down kind of any one thing. In melanoma, at least, there's some clinical parameters to suggest that patients with smaller tumors or a lower burden of cancer have a higher rate of response. There's some data to suggest that certain presence of mutations or frequency of mutations can predict likelihood of response, and that's been seen related to colon cancer and other cancers as well. Certainly expression of PD-L1, which is a protein that's expressed in the tumor and in the cells that surround the tumor, that we think is important in interacting with some of the PD-1 directed antibodies, which is a brake that acts on the immune system. And at this point, though, we're still trying to figure it out, I guess, is the short answer. And clinically, it's one of the biggest challenges we have.
Mm-hmm.
So in lung cancer,
I'm sorry, Dr. Carbone.
But
apologies for the audience that the screen should say who responds to immunotherapy, not what. Dr. Carbone, go ahead.
So in lung cancer, there seems to be better responses in patients who have a smoking history. Thus, the patients most likely to have EGFR mutations, for example, are the never smokers, and they are less likely to respond, though it's only a relative selection criterion. And it's pretty clear that overall the best responses are in patients that have high PD-L1 expression, though it's not a perfect predictor, and some with zero expression some patients whose tumors have zero expression have nice responses, and vice versa. But if you just lump all patients together, the number of responses are greater in patients with the highest PD-L1 expression in their tumors. Though in certain subsets of lung cancer, like squamous lung cancer, in a randomized clinical trials, it turns out that there was no difference in survival whether you had zero or high PD-L1. So as we just heard, there's no perfect test that can be used to pick people. But the fact is that the two most advanced first-line trials both selected patients for PD-L1 expression, and the recent press release stating that pembrolizumab improves survival compared to chemotherapy in first-line therapy of metastatic lung cancer is in patients who have been selected to express the PD-L1 marker.
Okay, great. And you touched on this, Dr. Carbone, in just that answer that you gave there, but what makes some tumors responsive and others not?
I wish I knew. There's no perfect way to tell, and like many things, nothing is 100% in oncology, but the response rates vary from single digits to 100% in various cohorts of patients and various combinations of immune therapy. There was recently a very small study in first-line therapy with a combination immunotherapy where 100% of the patients that were PD-L1 positive, high expressors, responded. So I think we are still actively researching how to figure that out. But right now, I think given how bad metastatic lung cancer is in specific and how bad second-line chemotherapy is, for example, I think it's a terrific new option for patients that is giving us more hope that we can further develop this therapeutic modality even better. And I hope that this is just the first wave of agents targeting the immune system, and that, like methotrexate and Cytoxan in the early days of lymphomas, that we will rapidly over the next decade develop new drugs and new combinations that target other immune suppressive mechanisms, and this will be a turning point in the treatment of otherwise awful cancers like metastatic lung.
Great. Dr. Salama, anything that you've seen in your research?
Just to add on to that, I think it's things that we're looking at are looking at some of the differences in patients whose cancers never respond to immune therapy versus patients whose tumors respond, and then we think they're having a benefit, and then they ultimately start growing again. So we kind of think about that in terms of mechanisms of resistance, of primary resistance versus acquired resistance. And so we're looking, here at Duke and patients on these immune therapies, at looking at biopsies at different points throughout their therapy to try to figure out some of the changes that occur and how they may be similar and overlap versus differences. And I agree, it's the question we really want to know, because it would ultimately help us pick the best therapy for our patients.
Mm-hmm. And how can a doctor predict who will respond to a specific therapy, and can a doctor even predict who will respond?
We've talked about that, and there are ways we can assess it as being more or less likely, but I think right now the answer is that we can't predict with any kind of certainty who's going to respond.
Mm-hmm. Mm-hmm. And how's immunotherapy changing the view of clinical trials?
For us, it is changing a little bit, in that prior to 2011, we really didn't, for melanoma, we really didn't have any therapy that had really demonstrated a survival benefit in a big kind of phase 3 study, which is sort of the standard. There were other therapies like high-dose IL-2 and other things that could benefit smaller percentages of patients. And so where previously I felt like most patients almost always wanted to go on a clinical trial, I think now there's a little bit more of a nuanced discussion, knowing that there are effective therapies that they could potentially get closer to home. Although I would say, and maybe I'm biased, but part of why we've made such progress in what feels like a short amount of time, but is really many decades in the making in terms of understanding the immune system, and certain processes that regulate the immune system, that participating in clinical trials is so important, because, as Dr. Carbone said, we really need to refine the types of combinations and how we can predict. And we've just been talking about how, while there's been all of this progress, we can't predict for any one patient with any certainty. So certainly like to say that clinical trials, I think, are still really important.
Mm-hmm. I would like to add to that with the fact that this is such a new therapy, especially for lung cancer doctors. Melanoma doctors have been using high-dose IL-2 and all kinds of other toxic immunotherapies in the past. But lung cancer doctors, like myself, who 20 years ago, the decision tree was very simple. You used the same thing for everybody, and it didn't work very well. Now there are many options for our patients. And for example, I've spent the last 10 years telling doctors they should never stop Tarceva for diarrhea, just treat it with Imodium. And I still find doctors that are mistreating or stopping Tarceva on their EGFR mutated patients because of a few episodes of diarrhea. Now with immunotherapies, the academic medical centers who've treated hundreds of patients have a much better handle on the toxicities of these therapies, especially the combination PD-1 and CTLA-4 targeted therapies, can have a fatal colitis that presents as diarrhea. So in one sense, I think that clinical trials will be performed at centers used to handling these agents, and I think can more safely give the drugs, especially the newer combinations. So I think that centers with clinical trials are likely to be safer in using these drugs and more effective than doctors who are trying them for the first time in the community. And the second thing is these drugs are being combined with virtually every other therapy for lung cancer and other cancers. In lung cancer, even if a surgeon tells you they got it all, you have about a 50% chance of having a recurrence. So immunotherapy is being combined with early stage lung cancer and before surgery, after surgery, with radiation, after radiation, with chemotherapy, with targeted agents. And I think we have a lot to learn about how to best combine this therapy with the standard therapies as well. And all those can only be done in the context of clinical trial.
Mm-hmm. And with all of these new advances and the potential for a durable response, do you think it's changing the way patients think about participating in trials?
I think it is to some extent for patients with melanoma, touching a little bit now, especially in light of combination immune therapies that have very high response rates, although they also have very high rates of toxicities. So touching on that, I think there are more options to think about. And I still, though, for all the reasons that I think Dr. Carbone said, still think clinical trials are often the best option, or still a really good option for patients, because we need to figure out how to optimize these therapies.
Yeah, and I think patients, as time has gone on, patients are more aware that clinical trials are more likely successful today than they were in the past. In the past, when we derived new drugs by scraping rocks and fungus off of rocks and grinding up tree bark and extracting it and trying it in people, today the therapies that are chosen for clinical trials are much more science-based and much more likely to be successful than they have been in the past. So we find that clinical trials are more and more the only way to get tomorrow's treatments today. And patients, I think, are coming to that realization.
So what's next for immunotherapy? What are some of the key questions that are being addressed today or should be addressed? And what can the benefits of immunotherapy, or how can the benefits of immunotherapy be maximized for more patients?
Well, we've touched on that a little bit. We have one class of agents that target PD-1 pathway, and we have another class of agents targeting a CTLA-4 pathway. But there's probably 20 other pathways that are known, and possibly many more that are unknown, that could be combined to be used together, or if we develop a better understanding of the immune system, we can measure characteristics of individual patients' tumors and immune systems and design specific combinations of therapy for their own tumor's immune environment. So I think the next phase in immunotherapy will be testing this second-generation immune modulators in combination or as single agents in an attempt to improve immunotherapy, and then also combining immunotherapies with known effective standard therapies, such as surgery or targeted therapy or radiation. And so the next generation of studies are going to address exactly what we've talked about, and that's the second question on this slide. And the key question is the same for immunotherapy that it is for any type of cancer therapy. Which patient, what treatment is going to give the best outcome with the least toxicity? And we're making progress, but we're not perfect at answering those questions.
Great. And Dr. Salama?
I would say I agree, and I think the flip side of that in terms of other important questions, or perhaps who doesn't need therapy or who doesn't need it for continuously, when we think about some of the way these therapies are given as it relates to cost and other issues, we're not sure that patients who are having a great response, that they truly need to continue on therapy. And with combination immune therapy, with the high rates of toxicities, interesting data was just presented at ASCO and melanoma to suggest that patients who stopped for toxicity with at least combination therapy had similar or even slightly higher response rates than patients who kind of continued on therapy and were doing well. Although I think it's small numbers of patients and early on. Also, some data presented to suggest that maybe patients who have a complete response, meaning we look at their scans and we don't see any evidence of active cancer, that perhaps they can be discontinued in terms of therapy and watched, and very few patients appear to recur. And I think that has a lot of meaning for patients in terms of quality of life and cost and sort of all of those other things that go in part with getting cancer therapy, and then at least in melanoma, also looking at these therapies in other patient populations, so patients who maybe don't have any evidence of active cancer, and looking at different therapies to see if immune therapy could prevent recurrence of their melanoma. We have some of these agents approved for that, although there are certain limitations to what's currently out there.
Wonderful. Thank you. So at this time, we have a number of questions that came in through the audience, so we'd like to jump right into those questions here. Dr. Carbone, Dr. Salama, are there people that are excluded from immunotherapy trials due to things like weight, diabetes, any other condition?
Well, the biggest exclusion is existing significant autoimmune disease. Since the therapies all rely on revving up your own immune system, if your immune system is already too revved up and attacking your body's cells, the normal cells in your body, I think it's dangerous to give immunotherapy. For example, somebody with active Crohn's disease or ulcerative colitis, giving them a combination immunotherapy probably would be a really bad idea. In addition, in lung cancer, I'm seeing more and more that some patients are reading about immune therapies, and it's getting so much attention in the media and in patient chat rooms, et cetera, that they want to forego standard therapy and to get immunotherapy. So, for example, a patient with surgically resectable lung cancer may say, I don't want surgery, I want immunotherapy, and I think that's a bad idea. And similarly, patients with EGFR mutations, untreated, newly diagnosed, should not get immunotherapy first line, should definitely get EGFR-targeted therapy. And so I think as with all advanced cancer therapies, there are patients who should get them and patients who should not get them. And that's becoming more and more complicated decision pathway in all cancers today.
Mm-hmm. Dr. Salama?
No, I would agree. I think the other patient population that maybe hasn't been very well studied or is just starting to be studied in terms of being excluded from a lot of these trials is patients with very symptomatic or what we call active brain metastasis. Certainly, it's of course. Dr. Carbone can attest to a problem in lung cancer as well and a problem in melanoma. And I think the key to remember is that a lot of these studies that the drugs received their approval from did not have many patients with brain metastases, or if they did, they were very, very small. So that's, it's not that the patient shouldn't get immunotherapy. It's just that kind of a careful discussion of the risk and benefits, and there are some potential concern for side effects related to that.
Great, thank you. In your experience, how effective is the mapping of tumors' genetics or their proteins and photoprotein pathways of operation and targeting those pathways? Any insight into that?
The modern technologies are very effective at mapping a genetic background of tumors. BRAF mutations in melanoma is a great example, but also BRAF mutations in lung cancer. The protein, and they probably mean phosphoprotein, not photoprotein pathways, is more experimental, but PD-L1, the biomarker we've been talking about, is a protein biomarker. And so there are many companies now that do these kinds of panel tests, Caris and Foundation Medicine, et cetera. But I can't speak for the specific one that's mentioned there. But if they have a CLIA-approved laboratory, then they should be giving generally reliable results. It's more, the issue is more in the interpretation of what to do with those results than in getting and ordering the results in the first place than actually getting a good test done.
Mm-hmm. Dr. Salama?
No, I just think adding to that as well that, there are many companies where these things are available and just thinking now about how we use that clinically, and certainly the NCI with the MATCH trial as well as other sponsored trials are trying to look at, perhaps do we categorize patients not according to tumor type, but perhaps according to genetic alteration and select a therapy based on that. And that's a bit of a paradigm shift as well, not kind of intertwined with immune therapy and how we think about it. And so certainly the testing is getting better. It's becoming more readily available, although I always encourage patients, I think that is best done in context with your oncologist and talking about risk and benefits. And it's, as Dr. Carbone alluded to, it's not just as easy as getting a test and getting a result back. There's a lot of interpretation about significance and meaning. So it's definitely always, I think, best to be done, with a physician.
Great, thank you. Our next question here is, how does the use of immunotherapy impact the use of conventional therapy, specifically for recurrence?
I think Dr. Carbone kind of touched on that as well. I mean, there's some instances where, maybe the standard therapy is a good therapy, like the case with EGFR targeted lung cancer and other, sort of therapies, although often when we think about recurrent cancer, we think about a more resistant type of cancer, and that may be a good place for immune therapy or a trial if something is not already approved.
Great, thank you. We have a question here that asks, what is your experience and suggestions for metabolic therapy through diet to boost the body's immune system to attack cancer? Any insights into that?
We get that question a lot. And
I was going to say it's one of my most common questions in clinic.
And I'd be very interested to see how Dr. Salama answers that question. But basically, I usually say that with modern therapies, the number one most important thing I tell patients is to not take anything that interferes with the therapy, because some of our current therapies are so effective that interfering with their metabolism, interfering with their absorption, interfering with their mechanism of action in any way, I think is clearly harmful. And beyond that, if you go into a nutrition center, you can find probably 100 different chemicals that are billed as boosting the immune response. And in general, I tell patients not to take them at all, just to eat a good, rounded, normal diet and maintain their weight. One thing that does suppress the immune system is weight loss and cachexia. So I think extreme diets are a bad idea as well. And in specific in lung cancer, in fact, many different vitamin therapies have been tried, antioxidants and beta-carotene, and every time they've been tried, they either have had no effect whatsoever, or selenium, for example, was recently tried, no effect at all, or actually the people taking the high-dose vitamins survived shorter or less long than the people that were on the placebo pills. So, Dr. Salama, what do you think?
I give a very sort of similar answer. I think I acknowledge the fact that certainly there's a powerful connection with nutrition and exercise and stress and how it can affect someone's general well-being, and I understand also the desire to want to actively contribute to kind of your own care and wellness. And I quote many of the same studies that we just, we don't have the information. Many of the studies of testing different supplements have never been shown to be beneficial. I think the other issue is many of these things are real drugs. So just because they're an herbal or an immune system, I use the quote I think Dr. Carbone referred to, that there are chemotherapies that are derived from natural sources, and so the effect that these may have on the liver, we're worried about immune therapy and inflammation of the liver. It can sometimes cloud the results, and so I generally advise as well to kind of stay away from any herbal supplements. I also caution that there's been some evidence to show we don't even know what's in those herbal supplements, that several major brands have been tested and they have varying amounts of what they report to have. So my short advice is to shop around the perimeter of the grocery store if they want to kind of make a diet change, and I try to leave it at that.
Wonderful, thank you. So we have a question here. It says, it's frustrating to be a prostate cancer patient with local lymph node metastasis without further metastatic incidence yet. It seems that all trials and advances only involve the sickest of the sick. What can I do to prepare now? Are there trials for non-metastatic patients?
Yes. We talked a little bit about that, how we're combining immunotherapy with early stage disease in the context of clinical trials. I don't know of a trial combining immunotherapy with early stage prostate cancer, but honestly, I wouldn't be surprised at all if there was one. So we're looking at these therapies in all stages of disease, but clearly it's generally true that new therapies are tested first in advanced situations, and that effective therapies often make their way to earlier stage disease, but immunotherapies really aren't at that stage yet, the ones we're talking about in specific, but we're studying it.
Great. Dr. Salama?
Yes, I think, some of our melanoma patients experience the same frustration, that there's been a lot of progress for patients with more advanced disease, and they describe it to me as feeling a little bit like a sitting duck, meaning they're told they have higher risk disease, and then we don't really have an effective option yet. And so it is being studied, though. There are trials that are ongoing now, and it is in this kind of period now of limbo where we're still learning about it. Although, being said, immunotherapy, we've talked about some of the benefits here of immunotherapy. They're focusing on a little bit on the risk, and that not everyone needs immune therapy, and that there can be kind of long-term risk with certain immune therapies, life-threatening risk, although it tends to be fairly low. So it's always something to think about. They are great therapies, and they may just not be for everyone.
Great, thank you. We have a question here that says, since most patients are treated in community oncology practices rather than big university research centers, how do you get community oncologists to evaluate for markers like PD-L1 expression? Any insights from your experience?
Well, I think that if for lung cancer in specific, and for first-line therapy, the approval is going to be tied to PD-L1 testing. And I think that community oncologists will rapidly adopt PD-L1 testing in order to offer their patients that therapy when those therapies become first line. In addition, one way that we try to hasten the process of education in the community is personally I go and do day trips to larger community practices in the region near where I am in central Ohio, and I'll just talk with the doctors there, and we'll give a little seminar on the latest advances in treating different types of cancer or immunotherapy in general, and then when they have patients, they feel comfortable in asking our opinion on the phone, and if the drugs are available locally, I will frequently work with community doctors to manage the patient locally. So I think it's a good idea for patients who are diagnosed with life-threatening cancer to get a second opinion at an academic center. I also think it's very reasonable to discuss with the doctors what options that are state-of-the-art are available in the community, and sometimes the best treatment is just as well given in the community as at an academic center.
Great. Another question here, it says, many patients with advanced or metastatic cancer would like to participate in a trial, but there are many barriers, such as long washout periods, distance to a research center. How are big research centers facilitating increased participation by decreasing these barriers? Are there anything that you're seeing being done at your specific institutions that are helping to address these barriers?
That's a That's a great question, and it's a big problem. Certainly where we are in North Carolina, sort of in the central part of the state, someone can still live in North Carolina and potentially have to drive 6 hours to get to Duke, and so we realize that that's just not possible. Certainly through cooperative groups, trials that are open at many sites, including many community practices. We have an oncology network here of other practices where we conduct, the main trial may be at Duke. It's also open at other sites, kind of spread throughout the different parts of our state, and it's a huge concern though in terms of access, and it's why most adult patients with cancer actually don't participate in clinical trials.
Dr. Carbone?
I think that there are distance barriers that are hard to overcome, but I think the people writing clinical trials today try to make them as low impact as possible in many of the ways that were touched on in the question. The frequency of visits, the number of blood draws, these kinds of things are really important in very early stage trials, but in the more advanced trials, they try to be as open and inclusive as is possible. But there's always a compromise, and trials have to be run in cohorts of patients that are as uniform as possible and as well studied as possible in order to be effectively interpreted. And so I think that it'll never be true that everybody will be able to get every treatment anywhere. But we recognize that's a problem. Ohio is a big spread out state too. It's got, I see a patient that comes 3 hours drive each way. But we try to minimize that and work, like I said, with the community doctors to get treatments outside as much as possible.
Great, thank you. And to the audience, if you have any other questions for our panelists, please go ahead and submit those through the question and answer box. I'll give it just a few more seconds here before we wrap up today's program.
So there was one question about germline testing or gene sequencing to improve prediction. That's actually an interesting question because there are many inherited polymorphisms or ways in which one person is different from another in genes that affect the immune response. And that's a wide open field that very little is known about. There are certain inter-individual differences that are inherited that can affect your ability to bind antibodies to macrophages, to recognize certain antigens by your T cells. And we're just learning about those sorts of things. And so that's an excellent question, but really right now, germline testing is not very useful for picking patients with immunotherapy. The somatic gene testing is proposed as being associated with efficacy of immunotherapy in the sense that the more mutations that are found when tumor genes are sequenced, the more likely that tumor is to respond. But right now, it's a relatively impractical test. But some of the genetic companies are now reporting mutation burden, it's called, in their genomics report, which does seem to be associated with immune response. So, like we've said repeatedly in this hour, we're learning about how to best combine all these things that are relatively associated with benefit from immunotherapy into predicting what an individual's likelihood of benefit is. But the good thing about these therapies, at least the single agent PD-1 targeted therapies like nivolumab or pembrolizumab, they're generally very low toxicity, especially compared to chemotherapy. So in a life-threatening disease like metastatic lung cancer, I think the best way to approach it, in my view, is to err on the side of treatment and see empirically until we have a better test that can define who's benefiting and who isn't.
Great, thank you. So we have a specific question here about lung cancer, Dr. Carbone, and just if you have any comments or suggestions for this person. Is there immunotherapy for limited stage recurrent small cell neuroendocrine lung cancer that is inoperable because of position and size? Radiation treatment is maxed out and standard chemotherapy left permanent kidney damage. Just any comments or suggestions for them?
Yeah, well, small cell lung cancer and another thoracic tumor called mesothelioma both have recently been reported to be good targets for immunotherapy, and patients with those diseases have significant response rates. And so there are many clinical trials that are ongoing or starting up targeting small cell lung cancer, and we have immunotherapy for recurrent small cell and first-line small cell. So I think if there's someone with no or few chemotherapy options left but good performance status, then they should seek out what nearby centers can use immunotherapy. However, if you have kidney damage, that could cause a problem with a clinical trial because often they exclude patients with kidney damage. As much as I'd like to see everyone receiving these treatments on a clinical trial, it's also possible to get these agents often if there's good data, if there are good data from meetings that report activity, and then we have been successful in getting the drug from companies for patients outside of a clinical trial, paid for by the company. So there are options for getting the drugs even in other situations, and small cell is one of those situations where we have been successful in getting these drugs off of trial for patients.
Okay, great. And we have a question here about secondary versus primary lung cancer. It says, my sister's adenoid carcinoma cancer has metastasized into her lungs. Would that be open for trials, or is that just for specifically lung cancer trials, or are those just for those with primary lung cancer?
Yeah, that's a common question. A cancer stays the same no matter where it goes. So adenoid cystic is a type of cancer of the salivary glands that very often goes to the lungs, but it is not lung cancer and would not be eligible for lung cancer clinical trials. That being said, clinical trials for adenoid cystic lung cancer would be what you should seek for the lung metastatic disease.
Okay, great, thank you. So that is all the time that we have today for this presentation. I want to just say thank you all for your enthusiasm and questions that have made today's panel discussion a great success. If you'd like some more information on immunotherapy, please go ahead and visit the Cancer Support Community website. We'd also like to thank our wonderful speakers, Dr. David Carbone and Dr. April Salama, for contributing their time and sharing this important information with us. The Cancer Support Community would also like to thank our program supporters, AstraZeneca and Merck. At this moment, you will be redirected to our post-webinar survey. Please take this survey as your input is of great value to us. Thanks again for your participation and have a great evening. Bye-bye.
Thank you.
Thank you.